Chapter 38, Critical Care of Patients with Neurologic Emergencies. The priority concepts in this chapter are perfusion and cognition. The interrelated concepts in this chapter are mobility and sensory perception. The first exemplar for this chapter is transischemic attacks. Acute neurologic emergencies are often associated with high mortality and severe morbidity and can create a significant and enduring impact on patients, their families, and society. Early recognition and comprehensive care of adults with acute neurologic compromise by the nurse and interprofessional healthcare team can reduce mortality. However, many patients who survive neurologic emergencies experience physical disabilities and possible mental health disabilities for the rest of their lives. Be aware that individuals with disability find hospitalization for any reason very frightening because they anticipate poor quality care, negative attitudes by nursing staff, and negative clinical outcomes. Acute neurologic problems from stroke, brain trauma, and malignancy cause varying degrees of impaired perfusion, cognition, mobility, and sensory perception. For our first exemplar, the transient ischemic attack, this is an acute ischemic stroke, often follows a warning sign such as a TIA. A TIA is a temporary neurologic dysfunction resulting from a brief interruption in cerebral blood flow. The symptoms of a TIA are easy to ignore or miss, particularly if symptoms resolve by the time the patient reaches the emergency department. Typically, symptoms of a TIA resolve within 30 to 60 minutes, but may last as long as 24 hours. On admission to the emergency department, a complete neurologic assessment is performed. The interprofessional team administers the National Institute of Health Stroke Scale, or the NIHSS, and other agency-specific assessment tools, routine laboratory tests, including coagulation tests, International Normalization Ratio, or the INR. The APTT and lipids and EKG and imaging scans are performed. The initial scan is typically a head CT followed by an MRI brain scan without contrast. Depending on agency protocol and the patient's assessment, a CTA or computer tomography angiography or a magnetic resonance angiography of the brain and neck is also performed to determine the patency of the carotid arteries, which provide perfusion to the brain and arterial circulation within the brain. Common causes of a TIA or stroke are carotid stenosis, which is hardening and narrowing of the artery, which decreases blood flow to the brain, often with atherosclerotic plaque buildup and atrial fibrillation. Atherosclerotic plaque consists of fat and other substances that adheres to the arterial walls and obstructs or restricts the flow. In addition to an NIH score, patients are often evaluated using the ABCD2 assessment tool to determine their risk of having a stroke in the days or weeks after the TIA. The following factors are scored. That would be the age greater than or equal to 60, stroke risk increases with age, blood pressure greater than or equal to 140/90, clinical TIA features, unilateral one-side weakness, which increases your stroke risk, and duration of symptoms. The longer the TIA symptoms last, the greater the risk for a stroke. Also, history of diabetes. Patients diagnosed with a TIA may or may not be admitted to the acute care hospital depending on their neurologic and cardiovascular status. For example, a patient who has a new onset of atrial fibrillation with a TIA or a TIA with carotid artery stenosis of greater than 70% will most likely be admitted depending on agency protocol. Some agencies have a dedicated TIA unit. Management of the patient who has had a TIA includes treatment of the cause if determined. Depending on the patient, collaborative interventions may include performing traditional or minimally invasive surgery to remove the atherosclerotic plaque buildup within the carotid artery and increase perfusion to the brain, performing a carotid angioplasty with stenting to increase perfusion to the brain, prescribing antiplatelet drugs, typically aspirin or Plavix to prevent thrombolytic or embolytic strokes, reducing high blood pressures, controlling diabetes and keeping the glucose levels within the target range, typically 100 to 180, and promoting lifestyle changes such as smoking cessation, eating more heart-healthy foods, and increasing mobility and physical activity. In collaboration with the interprofessional health team, we want to teach the patient about how to achieve a healthier lifestyle to prevent more TIAs or a major stroke. Provide them with information about community resources that can help them meet their desired outcomes. A stroke is caused by an interruption of perfusion of any part of the brain that results in infarction or cell death. Stroke is the leading cause of death, disability, dementia, and depression in the United States and throughout the world. While many improvements have been made to acute stroke care, the management of patients in stroke care transitions is lagging behind. The National Stroke Association uses the term brain attack to convey the urgency for acute stroke care, similar to the urgency provided for acute myocardial infarction, aka a heart attack. A stroke is a medical emergency and should be treated immediately to reduce or prevent permanent disability. The brain cannot store oxygen or glucose and therefore must receive a constant flow of blood to provide these substances for normal function. In addition, blood flow is important for the removal of metabolic waste, such as carbon dioxide and lactic acid. If perfusion in any part of the brain is interrupted for more than a few minutes, infarction occurs. Brain metabolism and blood flow after stroke can be affected around the infarction and in the contralateral or opposite side hemisphere. Each of the stroke on the non-affected side may be the result of brain edema or global changes in brain perfusion. As a result of brain edema, patients may develop increased cranial pressure and secondary brain injury. The secondary changes most commonly occur following a severe traumatic brain injury, and the discussion in this chapter will detail that. Types of strokes. Strokes are generally classified as ischemic or occlusive or hemorrhagic. Acute ischemic strokes are either thrombolytic or embolic in origin. Most strokes are ischemic. For an acute ischemic stroke, we are looking at this being caused by the occlusion or blockage of the cerebral or carotid artery by either a thrombus or an embolus. A stroke that is caused by a thrombus or clot is referred to as a thrombolytic stroke, whereas a stroke caused by an embolus, a clot, is referred to as an embolytic stroke. Thrombolytic strokes account for more than half of all strokes and are commonly associated with the development of atherosclerosis in either intracranial or extracranial arteries, usually the carotid artery. Atherosclerosis is the process by which fatty plaques develop on the inner wall of the affected arterial vessel. Rupture of one or more atherosclerotic plaques can promote clot formation. When the clot is of sufficient size, it interrupts blood flow to the brain tissue supplied by the vessels, causing an ischemic or occlusive stroke. The bifurcation, or the point of division of the common carotid artery with the internal carotid artery and the vertebral arteries at the junction with the basilar artery, are the most common sites involved in atherosclerotic plaque formation because of turbulent blood flow. Because of the gradual nature of clot formation with atherosclerotic plaque, the usual source of emboli is the heart. Emboli can occur in patients with atrial fibrillation, heart valve disease, mural thrombi after a myocardial infection, a prosthetic heart valve, or endocarditis. Another source of emboli may be the atherosclerotic clot that breaks off from the carotid sinus or internal carotid artery. Emboli tend to become lodged in small cerebral blood vessels to the point of the bifurcation or where the lumens narrow. As the emboli block the vessel, ischemia develops and the patient experiences the signs and symptoms of a stroke. The occlusion or blockage may be temporary if the embolus breaks into smaller fragments, enters small blood vessels, and is absorbed. For these reasons, embolic strokes are characterized by the sudden development and rapid occurrence of neurologic deficits. The symptoms may resolve over a few days. Conversion of an occlusive stroke to a hemorrhagic stroke may occur because the arterial vessel wall is also vulnerable to ischemic damages from blood supply interruption. Sudden hemodynamic stress may result in vessel rupture, causing bleeding directly from the brain. Hemorrhagic stroke. The second major classification of stroke is hemorrhagic stroke. In this type of stroke, vessel integrity is interrupted and bleeding occurs into the brain tissue or into the subarachnoid space. Intracerebral hemorrhage, or an ICH, describes bleeding in the brain tissue, generally resulting from a severe or sustained hypertension. Elevated blood pressure leads to changes within the arterial walls that leaves it likely to rupture. Damage to the brain occurs from bleeding, causing edema, inflammation, and displacement, which can put pressure on the brain tissue. Cocaine use is one example of a trigger of sudden dramatic blood pressure elevation leading to hemorrhagic stroke. Subarachnoid hemorrhage is much more common and results from bleeding into the subarachnoid space, the space between the pia mater and the arachnoid layers of the meninges covering the brain. These types of bleeding is usually caused by a ruptured aneurysm or an arterial venous malformation. An aneurysm is an abnormal ballooning or blister along a normal artery, commonly developed in a weak spot of the artery wall. Larger aneurysms are more likely to rupture than smaller ones. An arterial venous malformation is an angled collection of malformed thin-walled dilated vessels without a capillary network. These uncommon abnormalities occur during embryonic development. Vasospasms may occur as a result of a sudden and periodic constriction of the cerebral artery, often following a cerebral subarachnoid hemorrhage or bleeding from an aneurysm or an arteriovenous malformation rupture. This constriction interrupts blood flow to the area distal to the brain. Reduced perfusion from vasopressin contributes to secondary cerebral ischemia and further neurologic dysfunction. As with many health problems, the cause of stroke are likely a combination of genetic and environmental risk factors. The leading cause of stroke includes smoking, obesity, hypertension, diabetes mellitus, and elevated cholesterol. 1 in 3 U.S. adults will at least one of these conditions or of lifestyle habits. Many of these risk factors have a familial or genetic predisposition and are discussed elsewhere in this text. For example, first-degree relatives, mother, father, sister, brother, stroke risk increases, the strong family history of hypertension, atherosclerotic disease, and a diagnosis of aneurysm. Relatives of the patient with an aneurysm, regardless of vessel location, may be at a higher level for risk for intracranial aneurysm and should consider diagnostic testing and follow-up. Other risk factors for stroke include substance use disorder, especially cocaine and heavy alcohol consumption, and the use of oral contraceptives for women who have a risk for cardiovascular adverse effects. Stroke is the 5th leading cause of death and the leading cause of long-term disability in the United States. According to the U.S. Center for Disease Control and Prevention, more than 795,000 people experience a stroke each year, with 610,000 being a new stroke. Almost 150,000 Americans die each year from stroke. Women have a higher incidence of strokes than men, most likely because they tend to live longer. 8 southeastern states of the United States are known as the stroke belt because they have a mortality rate that is 20 to 50% higher than the rest of the nation. Possible factors influencing these differences include income, education, dietary habits, and access to health care. It is estimated that there are more than 7 million stroke survivors in the United States. Deaths from stroke have declined over the past few decades as a result of advances in prompt and effective acute medical management. However, the number of strokes occurring in the younger adult and middle-aged population is increasing. In this group, strokes are associated with illicit drugs because many street drugs have hypercoagulability, vasospasm, or hypertensive crisis side effects. Most strokes are preventable. The Healthy People 2030 initiative addresses the need to improve cardiovascular outcomes. The CDC and other cardiovascular professional organizations recommend applying the ABCs of heart health under medical supervision to prevent strokes. Aspirin use when appropriate, blood pressure control, cholesterol management, and smoking cessation. Lifestyle changes, including smoking cessation if needed, are a healthy diet rich in fruits and vegetables and low in saturated fats, including red meats, and regular physical activity, including planned exercise. We want to teach patients about the importance of identifying and managing risk factors such as hypertension, obesity, substance use disorders, diabetes mellitus. These will all contribute to the potential for a major stroke. Although an accurate history is important in the diagnosis of a stroke, the first priority is to ensure that the patient is transported to a stroke center. A stroke center is designated by the Joint Commission or other organization for its ability to rapidly recognize and effectively treat strokes. The Joint Commission designates two distinct levels of stroke center certification. The primary certified stroke center is required to provide diagnostic testing or imaging, stroke therapy with IV thrombolytic therapy, and a stroke team. The Comprehensive Stroke Center provides timely and advanced diagnostics and life-saving measures such as endovascular interventions and decomprehensive hemicranectomies, which can prevent long-term disability. Obtaining a history should not delay the patient's arrival to either the stroke center or the interventional radiology within the Comprehensive Stroke Center. A focus history to determine whether the patient has had any recent bleeding events or has taken an anticoagulant is an important part of the rapid stroke assessment protocol. There are several important parts of the history that should be collected. When did the symptoms begin? The time of onset of symptoms is essential for making treatment decisions. What was the patient doing when the stroke began? Hemorrhagic strokes tend to occur during activity. Ischemic strokes tend to occur early in the morning. How did the symptoms progress? Symptoms of a hemorrhagic stroke tend to occur abruptly, whereas thrombotic strokes generally have a more gradual progression. Did the symptoms worsen after the initial onset, or did they begin to improve? Improvement of symptoms could signify a warning TIA, or a waxing and waning of symptoms could signify an incomplete stroke dependent on perfusion. What is the patient's medical history? So what specific attention directed towards a history of head trauma, diabetes, hypertension, heart disease, anemia, and obesity? What is the patient's current medications, including prescribed drugs, over-the-counter drugs, herbal and nutritional supplements, and any recreational or illicit drugs? What's the patient's social history, including education, employment, travel, leisure activities, and personal habits? Do they smoke? What's their exercise pattern? Do they use drugs or alcohol? During the interview, observe the patient's level of consciousness and assess for indications of impaired cognition and mobility and sensory perception. We want to question the patient or family member about the presence of sensory deficits or motor changes, visual problems, problems with their balance or gait, communication problems, and changes in reading or writing abilities. Those when level of consciousness is suddenly decreased or altered, immediately determine whether hypoglycemia or hypoxia is present because these conditions may mimic emergent neurologic disorders. The patient with a subarachnoid hemorrhage, particularly when the hemorrhage is from a rupture or a leaking aneurysm, often report the onset of a sudden severe headache, described as the worst headache of my life. Additional symptoms of a subarachnoid hemorrhage or a cerebral aneurysmal or an arterial venous malformation bleeding are nausea and vomiting, photophobia, cranial nerve deficits, stiff neck, and a change in mental status. There may also be a family history of aneurysms. First responder personnel, which are paramedics, emergency medical technicians, perform an initial neurologic examination, which uses well-established stroke assessment tools. Nurses also perform a complete neuro assessment on arrival to the ED. The National Institute of Health Stroke Scale is a commonly used, valid, and reliable assessment tool that nurses complete as soon as possible after the patient arrives in the ED. This tool is used as one assessment to determine the eligibility of the IV fibrinolytics. Although the NIHSS is a standard tool for assessing neurologic status after an acute stroke, there's no standard for when or how often to use the tool. Implemented a quality improvement project to determine the minimum use of an NIH scale across their large healthcare system. As the patients are transitioned from the ED to other settings, the most important area to assess is the patient's level of consciousness. We want to use that Glasgow Coma Scale or a modified NIS to frequently monitor the change of levels of consciousness throughout the patient's acute care. Strokes and other neurologic injuries, including brain tumors or traumatic brain injuries, can cause an impaired airway defense or an inability to clear one's airway. This impairment can cause inadequate coughing and dysphagia, which can lead to aspiration or death. Therefore, assess the client's ability to effectively cough. Some agencies also allow nurses to use one of the variety of screening tools to assess for the presence of dysphagia. Stroke symptoms can occur at any time of the day or night. In general, the first 5 most common symptoms are sudden confusion or trouble speaking or understanding others, sudden numbness or weakness in their face, arm, or leg, sudden trouble seeing in one or both eyes, sudden dizziness, trouble walking, or loss of balance or coordination, sudden severe headache with no known cause. More specific stroke symptoms depend on the extent and location of the ischemia and the arteries and parts of the brain affected. The right cerebral hemisphere is more involved with visual and spatial awareness and preproposition or sense of body position. A person who has a stroke involving the right cerebral hemisphere is often aware of any deficits and may be disoriented at time and place. Personality changes, including impulsivity or poor impulse control and poor judgment, have results. The left cerebral hemisphere, this is the dominant hemisphere in people who are right-handed, which is 70% of the population. It is the center for speech, language, mathematics skills, and analytical thinking. Therefore, problems in this area are expected for patients who have a left-sided stroke. Patients with an embolytic stroke may have a heart murmur, dysrhythmias, most often atrial fibrillation, heart failure, endocarditis, and or hypertension. It is not unusual for patients to be admitted to the hospital with a blood pressure greater than 180 to 200 over 110 over 120, especially if they have hypertensive bleeding. Although somewhat high blood pressure of 150 over 100 is needed to maintain cerebral perfusion after an ischemic stroke. Pressures above this reading may lead to extension of the stroke. Psychosocial assessment. Assess the patient's reaction to the illness, especially in relation to the changes in their body image, self-concept, and their ability to perform ADLs. In collaboration with the patient's family and friends, we want to identify any problems with coping or personality changes. Screening and treatment for depression should be initiated and is the best practice guideline. Ask about the patient's financial status and occupation because they may be affected by the residual neurologic deficits of the stroke, and this could be potentially a long recovery. Patients who do not have disability or health insurance may worry about how their family will cope financially with this disruption in their life. Early involvement of social services and certified hospital chaplains or psychological counseling may enhance coping skills. We want to assess for emotional ability or uncontrolled emotional states, especially if the frontal lobe or right side of the brain has been affected. In such cases, the patient often laughs and then cries unexpectedly for no apparent reason. We want to explain the cause of uncontrolled emotions to the family or significant others so that they do not feel responsible for these reactions. Clinical history, physical assessment, and the NIH stroke scale score are usually enough to identify stroke once it's occurred. No definitive laboratory tests confirm its diagnosis. However, elevated hematocrit and hemoglobin levels are often associated with a severe or major stroke as the body attempts to compensate for lack of oxygen to the brain. An elevated white blood cell count may indicate the presence of an infection or a response to a physiologic stress or inflammation. Blood glucose and hemoglobin A1C level are used to evaluate whether the client has diabetes and whether it is controlled. In addition to other routine laboratory testings, the primary care provider typically requests a PT, an INR, and an APTT to establish baseline information before fibrinolytic or anticoagulation therapy may be started. For imaging, we could use a definitive evaluation of a suspected stroke by utilizing a computed tomography perfusion scan and or a computer tomography angiography. to assess the extent of ischemia of brain tissue. Cerebral aneurysms or arteriovenous malformations may also be identified. Magnetic resonance angiography and multimodal techniques such as perfusion-weighted imaging enhance the sensitivity of the MRI to detect early changes in the brain, including confirming blood flow. Ultrasonography of the carotid duplex scanning may also be performed. The patient with a stroke is expected to improve cerebral perfusion to maintain adequate brain function and prevent further brain injury. Most strokes are treatable. Improvements in acute stroke management have helped to decrease death from stroke. Almost all large hospitals in the United States have designated stroke centers. However, community and rural acute care settings may not have access to a neurologist or other resources needed to manage an acute stroke. As a result, teleneurology, examining hospitals that use two-way video healthcare technology, is a growing strategy to provide acute stroke consultations with board-certified neurologists. In a study examining hospitals that use teleneurology for stroke and found that there was more likely to give a fibrolytic or a clot-busting drug alteplase than hospitals without teleneurology. As a result, clinical outcomes are better for patients in hospitals that use teleneurology when compared to the hospitals that do not. Interventions for patients experiencing stroke are determined primarily by the type and extent of the stroke. Nursing interventions are initially aimed at monitoring for neurologic changes or complications associated with stroke and its treatment. The two major treatment modalities for patients with acute ischemic stroke are IV fibrolytic therapy and endovascular intervention. Regardless of the immediate management approach used, once the patient is stable, we want to provide ongoing supportive care, provide interventions to prevent and/or monitor for early signs of complications, and implement interventions to prevent patient falls. These health problems are discussed in later chapters. For fibrolytic therapy, for selected patients with acute ischemic strokes, early intervention with IV fibrolytic therapy is a standard of practice to improve blood flow to viable tissue around the infarction or through the brain. The success of fibrolytic therapy for the stroke depends on the interval between the time that symptoms begin and the treatment is available. IV systemic fibrolytic therapy, also called thrombolytic therapy, for an acute ischemic stroke dissolves the cranial artery occlusion by reestablishing blood flow and preventing cerebral infarction. IV alteplase is the only drug approved at this time for the treatment of acute ischemic stroke. The most important factor is determining whether to give alteplase is the time between symptom onset and the time seen in the stroke center. Currently, the FDA approves administration of alteplase within 3 hours of the stroke onset. The American Stroke Association endorses extension of that time to 4.5 hours to administer fibrolytics for patients unless they fall into one or more of the categories below, which include adults older than 80, anticoagulation regardless of international normalized PT-INR, imaging evidence of ischemic injury involving one or more than 1/3 of the brain tissue supplied by the middle cerebral artery, baseline NIHS score of greater than 25, history of both strokes and diabetes, and evidence of active bleeding. Fibrolytic therapy is explained to the patient and the family member, and informed consent is obtained. The dose of alteplase is based on the patient's actual weight of 0.9 milligrams per kilogram. The 2019 Clinical Practice Guidelines for Management of Patients with Ischemic Acute Stroke recommended IV alteplase at 0.9 milligrams per kilogram over 60 hours, with the initial 10% of the dose given as a bolus over the first minute. The newest recommendation for door-to-needle time is 45 minutes. Each hospital has a strict protocol for mixing and administering fibrolytic drugs and for monitoring the patient between and after fibrolytic drug administration. In some cases, the patient's blood pressure may be too high to be given medication. In this instance, the patient receives a rapid-acting antihypertensive drug until the blood pressure is below 185/110. The level must be maintained during fibrolytic therapy. Endovascular interventions are procedures to improve perfusion, including intra-arterial thrombolysis using drug therapy, mechanical embolectomy, which is a surgical blood clot removal, and carotid stent placement. Intra-arterial thrombolysis has an advantage of delivering defibrillating agent directly to the thrombus within 6 hours of the stroke onset. It is particularly beneficial for some patients who have an occlusion in the middle cerebral artery, or those who arrive at the ED after a window for IV alteplase. Patients have either fibrinolytic therapy and/or endovascular interventions are admitted to a critical care setting for intense monitoring. Carotid artery angioplasty with stenting is common to prevent or, in some cases, help manage an acute ischemic stroke. This interventional radiology procedure is usually done under moderate sedation and may be performed by a cardiovascular surgeon or interventional radiologist. A technique uses a distal embolytic protection device, made this procedure very safe. The device is placed between the stenosis through a catheter inserted into the femoral artery or radial artery. The device catches any clots that break off during the procedure. Placement of a carotid stent is performed to open the blockage in the carotid artery, typically at the division of a common carotid artery into the internal and external carotid arteries. Throughout the procedure, careful assessment of the patient's neurologic and cardiovascular status is a must. When a stroke is hemorrhagic and the cause is related to an arterial venous malformation or a cerebral aneurysm, the patient is evaluated for the optimal procedure to stop further bleeding. Some procedures can be used to prevent bleeding in an arterial venous malformation or aneurysm that is discovered before symptom onset of a cerebral hemorrhage. Procedures occur in the interventional radiology suite or operating room where monitoring for increased intracranial pressure. The patient is most at risk for an increased ICP resulting from edema during the first 72 hours after onset of a stroke. Some patients may have worsening of their neurologic status starting within 24 to 48 hours after their endovascular procedure from increased ICP. We want to reassess the patient with acute stroke and after endovascular therapy of stroke symptoms every 1 to 4 hours, depending on the severity of the condition. We use the approved agency assessment strategy and documentation tools. Best practices for preventing or managing increased intracranial pressure for patients experiencing a stroke include elevating the head of bed per agency or primary healthcare provider protocol to improve perfusion pressure, provide oxygen therapy to prevent hypoxia for patients with oxygen saturation of less than 95%, maintain the head in a midline neutral position to promote venous drainage from the brain, avoid sudden and acute hip or neck flexions during positioning. Extreme hip flexion may increase intrathoracic pressure, leading to decreased cerebral venous outflow and increased intracranial pressure. We want to avoid extreme neck flexion as well, which also interferes with that venous drainage from the brain and intracranial dynamics. We want to avoid the clustering of nursing procedures. When multiple activities are clustered in a narrow time, the effect of ICP can be a dramatic evaluation and elevation. We want to hyperoxygenate the patient before and after suctioning to avoid transient hypoxemia and resultant ICP elevation from dilation of the cerebral arteries. Provide airway management to prevent unnecessary suctioning and coughing that can increase the ICP. Maintain a quiet environment that the patient is experiencing a headache, which is common with a cerebral hemorrhage or increased ICP. Keep the room lights low to accommodate for photophobia with the patient. And closely monitor blood pressure, heart rhythm, oxygen saturation, blood glucose, and body temperature to prevent secondary brain injury and promote positive outcomes after stroke. The 8 core measures of ischemic stroke care for all patients include venous thromboembolism prophylaxis, discharge with antithrombolytic therapy, discharge with anticoagulation therapy for AFib or flutter, thrombolytic therapy as indicated, antithrombolytic therapy reevaluated by end of day 2, discharge on statin medication, stroke education provided and documented, and assessment for rehabilitation. Ongoing drug therapy depends on the type of stroke and the resulting neurologic dysfunction. In general, the purpose of drug therapy are to prevent further thrombolytic or embolytic episodes and to protect the neurons from hypoxia. Antiplatelet drugs such as aspirin and Plavix are the standard of care for treatment following acute ischemic strokes and for preventing further strokes. Sodium heparin and other anticoagulants such as warfarin, a vitamin K antagonist, or non-VKA or direct oral anticoagulants are reserved for use in patients who have cardiopulmonary issues such as atrial fibrillation. Anticoagulants are high-alert drugs that can cause bleeding, including intracerebral hemorrhage in the area of the ischemia. A newer trend is to prescribe a direct oral anticoagulant rather than bridging heparinoids, such as a low molecular weight heparin or unfractionated heparin for patients with acute ischemic stroke. A study by Altavilla et al. Showed a decrease in the incidence of bleeding and stroke reoccurrence by giving a direct oral anticoagulant instead of warfarin with bridging therapy. An initial low-dose aspirin is safer and recommended within 24 to 48 hours after stroke onset. Aspirin should not be given within 24 hours of fimbric administration, however. Aspirin is an antiplatelet drug that prevents further clot formation by reducing platelet adhesiveness or clumping and stickiness. It can cause bruising, hemorrhage, and liver disease over a long period of time. Teach the patient to report any unusual bleeding or bleeding to the primary care provider or to call 911 if the bleeding is severe or does not stop. A calcium channel blocking drug that crosses the blood-brain barrier, such as nimipapine or Nimtold, may be given to treat or prevent cerebral vasospasm after a subarachnoid hemorrhage. Vasospasm, which usually occurs within 4 to 14 days after stroke, slows blood flow to the area and causes ischemia. Nimpop works by relaxing the smooth muscles of the vessels walls and reducing the incidence and severity of the spasm. In addition, this drug dilates collateral vessels to ischemic areas of the brain. Stool softeners, analgesics for pain, and anti-anxiety drugs may be prescribed as needed for symptom management. Stool softeners are present to prevent the vasovagal maneuver or the Valsalva maneuver during defecating to prevent increased intracranial pressure. For mobility and ADL ability, the patient with a stroke is expected to ambulate and provide self-care independently with or without one or more assistive adaptive devices. In collaboration with the rehab therapist, assess the patient's functional abilities for bed skills, ambulation with or without assistance, ADL abilities including feeding, bathing, and dressing. The patient who has had a stroke is at a high risk for aspiration due to impaired swelling as a result of muscle weakness. Therefore, the best practice of all suspected and diagnosed stroke patients is to maintain an NPO status until the swallowing ability is assessed. We want to follow our agency guidelines for this and make sure that we're doing the screening and the evidence-based bedside swallowing screening to determine if the dysphagia is present. We want to refer the patient to a speech-language pathologist for a swallowing evaluation per stroke protocol as needed. If dysphagia is present, we want to develop a collaborative plan of care to prevent aspiration and support nutrition. Collaborate with a registered dietitian, nutritionist to ensure that the nutritional needs are met. Monitor the patient's weight daily and serum prealbumin levels to detect any decrease from baseline. Many patients who have an untreated stroke often have flaccid or spastic paralysis. It is not unusual for a patient to eventually become flaccid or spastic on the affected side. We want to make sure that when this is happening, we are assisting with the patient to help them protect that area that no longer is functioning as it had been before. If we don't protect it with something like a sling, we can actually cause someone's shoulder to sublux or their leg to stop working entirely. So some core measures for venous thromboembolism is, again, utilizing that anticoagulant to assist. To help communicate with the patient with aphasia, if they have that, you want to use the guiding principles of present one idea or thought in a sentence. So I am going to get help. You get into the chair. Use simple one-step commands rather than asking patient to do multiple things, speak slowly but not loudly, using cues or gestures as needed, avoid yes or no questions for patients with expressive aphasia, use alternative forms of communication if needed, such as computer, handheld mobile device, communication board, or flashcards, often with pictures, and do not rush the patient when speaking. The major concern of patients with sensory perception deficits is the adaptive of neurologic deficits. The patient with a stroke is expected to adapt to sensory perception changes in vision, pre-application, which is the body position sense, and or peripheral sensation, and to be free from injury. For interventions, the patient with the right hemisphere brain damage typically have difficulty with their visual perceptual or spatial perceptual tasks. They often have problems with depth and distance perception and with discrimination of right from left or up from down. Because of these problems, patients have difficulty with performing routine ADLs. Caregivers can help the patient adapt to these disabilities by using frequent verbal and tactile cues and by breaking down tasks into discrete steps. Always approach the patient from the unaffected side, which should face the door of the room. Unilateral neglect or inattention occurs most commonly in patients who have a right cerebral stroke. However, it can occur in any patient who experiences hemiplegia, in which the vision of one eye or both eyes is affected. This problem places the patient at risk for injury, especially falls, because of the inability to recognize physical impairment of one side of the body or because of the lack of proprioception. Teach the patient to touch and use both sides of the body. When dressing, remind the patient to dress the affected side first. In homonymous hypophagia, if is present, teach the patient to turn their head from side to side to expand their visual field because the same half of each eye is affected. The scanning technique is also used for when patients is eating or ambulating. Want to place objects within the patient's field of vision. A mirror may help visualize more of the environment. If the patient has double vision or blurred vision, a patch may be placed over the affected eye and changed every 2 to 4 hours. The patient with a left hemisphere lesion generally has memory deficits and may show significant changes in their ability to carry out simple tasks such as eating and grooming, help with ADLs, but encourage the patient to do as much as they can independently. Nurses not only provide direct acute care for the patients with stroke, but they also continue to the peer review process to evaluate and monitor the care provider for patients with stroke who are planning transition from hospital to continued care. Many hospitals are developed transition of care systems to improve patient and family education, patient and family satisfaction, and a 30-day hospital readmission rate. A classic systemic review of the literature can be found that discharge education utilizing a teach-back method can reduce a 30-day readmission by 45%. The concept of hospital at home is gaining popularity and can offer high acuity care for the patient with 24/7 telemedicine monitoring, as well as acute care provider by specialized nurses and healthcare providers. Improved clinical outcomes have been demonstrated during the first 30 post-acute days to include a decrease in hospital readmissions, a decrease in utilization of the ED, and a decrease in transfers to skilled nursing facilities. Technology innovations in mobile health and telemedicine have offered new methods to extend care remotely to patients with stroke after hospital discharge. These methods include implantable loop monitors and follow-up virtual visits. The next exemplar that was covered in the book was traumatic brain injury, and this is damage to the brain from an external mechanical force and not caused by a neurodegenerative or a congenital condition. TBI can lead to temporary and permanent impairment in cognition, mobility, sensory perception, and or psychosocial function. As the term implies, patients who have any type of TBI experience trauma. The stress that follows a traumatic event affects each individual differently and can lead to long-lasting physical, mental, emotional, social, and spiritual distress. Nurses and other members of the interprofessional healthcare team need to be aware of these effects and provide trauma-informed care as part of the patient-centered approach, which is described later in interprofessional collaborative care. Various terms are used to describe the brain injuries that occur when a mechanical force is applied either directly or indirectly to the brain. A force produced by a blow to the head is a direct injury, whereas a force applied to another body part with a rebound effect to the brain is an indirect injury. The brain responds to these forces by movement within the rigid cranial vault. It may also rebound or rotate on the brainstem, causing diffuse nerve axonal injury or shearing injuries. The brain may be contused or bruised or lacerated, torn, as the movement over an inner surface of the cranium, which are irregularly shaped and sharp. Movement or distortion within the cranial cavity is possibly because of multiple factors. The first factor is how the brain is supported by cerebrospinal fluid within the cranial cavity. When external force is applied to the head, the brain can be injured by the internal surfaces of the skull. The second factor is the consistency of the brain tissue, which is very fragile, gel-like, and prone to injury. Brain injury occurs both from initial forces of the cranium and brain and as a result of secondary injury related to mechanical pressure or cerebral edema. The type of force and the mechanism of injury contribute to TBI. An acceleration injury is caused by an external force contacting the head, suddenly placing the head in motion. A deceleration injury occurs when the moving head is suddenly stopped or hits a stationary object. These forces may be sufficient to cause the cerebrum to rotate about the brainstem, resulting in shearing, straining, and distortion of the brain tissue, particularly in the axons of the brainstem and cerebellum. Small areas of hemorrhage, contusion, intracranial hemorrhage, may develop around the blood vessels that sustain the impact of the forces, with destruction of adjacent brain tissue. Particularly affected are the basal nuclei and the hypothalamus, which are located deep in the brain. Primary brain injury occurs at the time of injury and results from the physical stress or force within the tissue caused by blunt or penetrating force. A primary brain injury may be categorized as focal or diffuse. A focal brain injury is confined to a specific area of the brain and causes localized damage that can often be detected with a CT scan or MRI. Diffuse injuries are categorized by damage throughout many areas of the brain. These begin at a microscopic level and are not initially detectable on a CT scan. MRI has greater ability to detect these injuries, but their areas may not be imaged until necrosis occurs. Primary brain injuries are also classified as either open or closed. An open traumatic brain injury occurs when the skull is fractured or when it is pierced by a penetrating object. The integrity of the brain and the dura is violated, and their exposure to environmental contaminants. Damage may occur to the underlying vessels, dural sinuses, brain, and cranial nerves. In a closed traumatic brain injury, the integrity of the skull is intact, but damage to the brain tissue still occurs as a result of increased intracranial pressure or internal forces. TBI is further defined as mild, moderate, or severe. Generally, the determination of severity of a TBI is a result of the Glasgow Coma Scale score immediately following resuscitation, the presence or absence of brain damage imaged by CT or MRI following the trauma, an estimation of the force of the trauma, the symptoms to the injured person. One type of mild TBI is a concussion. A concussion is a traumatic injury to the brain caused by a blow to the head and may or may not result in some period of unconsciousness. Military personnel and people who participate in recreational professional sports are especially at risk for concussions. Some patients report no immediate symptoms until later, which typically includes impaired cognition, such as memory or thinking processes, and headaches. A secondary brain injury is an injury to the brain that includes any process that occurs after the the initial injury and worsens or negatively influences patient outcomes. Secondary injuries result from physiologic, vascular, or biochemical events that are an extension of the primary injury. The most common secondary injury from a mild TBI, sometimes documented as an MTBI, such as a concussion, is a post-concussion syndrome. In this syndrome, the patient reports that headache, impaired cognition, and dizziness continue to occur for at least 4 weeks after the initial brain injury. Other patients who have been diagnosed with concussions may experience only post-traumatic headaches or post-traumatic vertigo for weeks to months after the initial injury. Additional symptoms of post-concussion syndrome that may occur are irritability, depression, anxiety, emotional lability, insomnia, difficulty concentrating or memory deficit, and reduced alcohol tolerance. Some patients may not have diagnosed as having a TBI because they're asymptomatic. However, later they may be diagnosed with a chronic traumatic encephalopathy, an uncommon degenerative brain disease that occurs most often in military veterans, athletes, and others who've experienced repetitive trauma to the brain. A chronic traumatic encephalopathy can lead to dementia, depression, suicidal thinking, and substance use disorder. Although the disease is usually diagnosed by history and clinical presentation, it can only be confirmed at autopsy when the classic tau neurofibrillary tangles are evidence. Another syndrome that can occur is a second impact syndrome. SIS is rare, and there is not an exact understanding of the pathophysiology. SIS occurs when the brain has not fully recovered from the initial TBI and so sustains a second impact before recovery. The patient will rapidly develop altered mental status and a loss of consciousness within seconds to minutes of the second hit, resulting in a catastrophic neurologic injury. Most of these injuries occur in athletes. School nurses are in an ideal position to educate the public, coaches, parents, and athletes on the prevention of concussion and return to sports guidelines. For patients with moderate to severe traumatic brain injuries, the most common secondary injuries result from hypotension and hypoxia, intracranial hypertension, and cerebral edema. Damage to the brain tissue occurs primarily because the delivery of oxygen and glucose to the brain is interrupted from cerebral edema and increasing pressure. Each of the problems is discussed in the following sections. Both hypotension, defined as the mean arterial pressure of less than 70 millimeters of mercury, and hypoxemia, defined as a particular pressure of arterial oxygen less than 80, restrict the flow of blood to vulnerable brain tissue. Hypotension may be related to shock or other states of reduced perfusion to the brain, such as the cause of clot formation. Hypoxia can be caused by respiratory failure, asphyxiation, or loss of airway and impaired ventilation. These problems may occur as a direct result of moderate to severe brain injury or secondary to systemic injuries and comorbidities. Low blood flow and hypoxemia contribute to cerebral edema, creating a cycle of deteriorating perfusion and hypoxic damage. Patients with hypoxic damage related to moderate to severe brain damage face a poor prognosis and eventually experience impaired cognition. The cranial contents include brain tissue, blood, and cerebral spinal fluid. These components are encased in a relatively rigid skull. Within this space, there is a little room for any of the components to expand or increase in volume. A normal level of intracranial pressure is 10 to 15 millimeters of mercury. Periodic increases in pressure occur with straining during defecation, coughing, or sneezing, but do not harm the uninjured brain. A sustained intracranial pressure of greater than 20 millimeters of mercury is considered detrimental to the brain because neurons begin to die. As a result of brain injury, the increase in the volume of one component must be compensated by a decrease in the volume of one of the other components. As a first response to an increase in the volume of any of the components, the cerebral spinal fluid is shunted or displaced from the cranial compartment to the spinal subarachnoid space, or the rate of cerebrospinal fluid absorption is increased. An additional response is needed is a decrease in cerebral blood volume by movement of cerebral venous blood into the sinuses or jugular veins. As long as the brain can compensate for the increase in volume and remain compliant, Increases in intracranial pressure are minimal. Increases in intracranial pressure is a leading cause of death from head trauma in patients who reach the hospital alive. It occurs when compliance no longer takes place and the brain cannot accommodate further volume changes. As intracranial pressure increases, cerebral perfusion decreases, leading to brain tissue ischemia and edema. If edema remains untreated, the brainstem may herniate downward through the foramen magnum or laterally through the unilateral lesion within one cerebral hemisphere, causing irreversible brain damage and possible death. From brain herniation syndromes, which are discussed later, it shows that they are associated with an increase in intracranial pressure. Hemorrhage, which causes a brain's hematoma, or a collection of blood or clot, may occur as part of the primary injury begin at the moment of impact. It may also arise later from vessel damage as a secondary brain injury. Bleeding is caused by vascular damage from the shearing force of the trauma, or direct physical damage from skull fracture or penetrating injury. All hematomas are potentially life-threatening because they act as space-occupying lesions and are surrounded by edema. Three major types of hemorrhage after a TBI are epidural, subdural, and intercerebral hemorrhage. Subarachnoid hemorrhage may also occur. An epidural hematoma results from arterial bleeding in the space between the dura and the inner skull. It is often caused by a fracture of the temporal bone, which houses the middle meningeal artery. Patients with epidural hematomas have lucid intervals that last for minutes, during which the patient is awake and talking. This follows by a momentary unconsciousness that can occur within a minute of the injury. A subdural hematoma results from venous bleeding into the space beneath the dura and above the arachnoid. It occurs most often from a tearing of the bridging veins within the cerebral hemispheres from a laceration of brain tissues. Bleeding from this injury occurs more slowly than that with an epidural hematoma. Subdural hematomas are subdivided into acute, subacute, and chronic. Acute subdural hematomas present within 48 hours after impact, subacute subdural hematomas between 48 and 2 weeks, and chronic subdural hematomas from 2 weeks to several months after injury. Subdural hematomas have the highest mortality rate because they are often unrecognized until the patient presents with severe neurologic compromise. The incidence of chronic subdural hematomas, sometimes written as CSDH, nearly doubles when people are between 65 and 75 years of age and continues to increase in patients over 80 years old. Common causes of a chronic subdural hematoma in older adults includes head trauma resulting from a fall and anticoagulant or antiplatelet therapy. Typical signs and symptoms include worsening headaches, paresis, acute confusion, and seizures. In some cases, patients may experience a decreased level of consciousness, including a coma. Traumatic intercerebral hemorrhage is the accumulation of blood within the brain tissue caused by the tearing of small arteries and veins in the subcortical white matter. It often acts as a space-occupying lesion and may be potentially devastating depending on its location. Intracranial hemorrhage may also produce significant brain edema and intracranial pressure elevations. A traumatic brainstem hemorrhage occurs as a result of a blow to the back of the head, fractures, or torsion injuries of the brainstem. Vital sign center. Brainstem injuries have a very poor prognosis. Brain herniation syndromes. In the presence of increased intracranial pressure, the brain tissue may shift and herniate downward. Of the several types of herniation syndromes, uncanal herniation is one of the most clinically significant because it's life-threatening. It is caused by a shift of one or both areas of the temporal lobe known as the uncus. This shift creates pressure on the third cranial nerve or the ocular motor. Later findings include dilated and non-reactive pupils, eyelid drooping, and a rapid deteriorating level of consciousness. Central herniation is caused by a downward shift of the brainstem and the diencephalon from a supratentorial lesion. It manifests clinically with Cheyne-Stokes respirations and pinpoint reactive pupils initially, then it may progress to non-reactive pupils and potentially hemodynamic instability. All herniation symptoms are potentially life-threatening, and a rapid response team or primary health care provider must be notified immediately when they are suspected. Hydrocephalus is an abnormal increase in cerebrospinal fluid volume in the brain. May be caused by impaired reabsorption of cerebrospinal fluid at the arachnoid villi from the subarachnoid hemorrhage or a meningitis, called a communicating hydrocephalus. It also can be caused by interference or blockage from cerebrospinal fluid outflow from a ventricular system, like cerebral edema, a tumor, or debris. This is called a non-communicating hydrocephalus. The ventricles may dilate from the relative increase in the cerebrospinal volume. Ultimately, if not treated, additional cerebrospinal fluid may lead to increased intracranial pressure. The most common causes of a traumatic brain injury in the United States are falls, unintentional self-harm, motor vehicle crashes, and assaults. Falls among older adults are increasing as many baby boomers reach older adulthood. Firearm-related suicide is the most common cause of a traumatic brain injury-related death in the United States. Alcohol and illicit drugs are significant contributing factors to the causes of TBIs. Summer and spring months, evenings, nights, and weekends are associated with the greatest number of injuries. Young males are more likely than young females to have a TBI. Men tend to play more sports, enroll more often in military services, take more risks when driving, and consume larger amounts of alcohol than women. Falls are the most common cause of TBI in older adults and children. Over 3 million people sustain a TBI in the United States every year. Of these, more than 56,800 die. The number of TBI-related emergency department visits, hospitalizations, and deaths has increased over the past several decades. In Canada, statistics are calculated for acquired brain injuries, which include both traumatic and non-traumatic brain injuries such as strokes. Nurses can educate the public on ways to decrease the incidence of TBI by using safe driving practices such as wearing seat belts and never driving while impaired. Teach people at risk about how alcohol and illicit drug use, including the use of marijuana, affect driving ability. Promote the use of helmets for skateboarding and bicycle and motorcycle riding. Teach gun safety to prevent unintentional injuries. Help prevent falls by providing a safe environment, especially for older adults. People need to be aware of environmental factors such as inadequate lighting and loose rugs that may increase the likelihood of falls. When possible, instill safety equipment in bathtub and showers. Evaluate balance and coordination as part of a fall prevention strategy inside the hospital and at home. Obtaining an accurate history from a patient who has sustained a TBI may be difficult because of changes in the patient's cognition. The seriousness of the injury can cause amnesia or loss of memory. It is not unusual for the patient to experience amnesia for events before or after the injury. The patient with a moderate to severe brain injury may be unconscious or in a confused and combative state. If the patient cannot provide the information, the history can be obtained from first responders or witnesses to the injury. Always ask when, where, and how the injury occurred. Did the patient lose consciousness? If so, for how long? Has there been a change in the level of consciousness? If trauma is related to drugs or alcohol consumption, it may be difficult to differentiate neurologic changes caused by head trauma from those produced by intoxication. We want to determine whether the patient had fluctuating consciousness or seizure activity and whether there is a history of seizure disorder. Obtaining precise information about the circumstances of falls, particularly in the older patient, is important to let us know how we're going to move forward with care. Other pertinent information includes hand dominance, any disease of or injuries to the eyes, and any allergies to drugs or food. Inquire about a history of alcohol or drugs because the Commission and the Center of Medicare and Medicaid requires that all patients be screened for abuse and neglect when they are admitted to this type of healthcare facility. No two brain injuries are alike. The patient with a TBI may have a variety of signs and symptoms depending on the severity of the injury and the resulting increase in intracranial pressure. For many patients with a TBI, we have to assess for signs of increased intracranial pressure, hypotension, and hypoxemia. The first priority in this assessment is, again, the ABCs, airway, breathing, and circulation. Because TBI is occasionally associated with a cervical spine injury, all patients with head trauma are treated as though they have a cord injury until radiography proves otherwise. Older adults are especially prone to cervical injuries at the first or second vertebrae level, which is a life-threatening problem. So we want to assess for indicators of spinal cord injury, such as less mobility and sensation perception, tenderness along the spine, and abnormal head tilt. Injuries to the brainstem may cause a major life-threatening change to the person's breathing patterns, such as Cheyne Stokes respirations and/or apnea. In the unconscious patient, an artificial airway provides protection from aspiration and a route for oxygenation. Mechanical ventilation is often needed to support inadequate client respiratory effort. Patients with blunt trauma to the head or neck are typically transported from the scene of the injury to the hospital with a rigid cervical collar and a long spine board. The expected outcome is to prevent new and secondary spine injuries. Spine precautions require placing the patient supine and aligning the spinal column in a neutral position so that there is no flexion, rotation, or extension. The long spine board is removed as soon as possible on arrival to the emergency department or ICU. The rigid cervical collar is to maintain in place until definitive diagnostic studies have ruled out cervical spine injury. Once the spine board is removed, spinal precautions are maintained until the primary healthcare provider indicates that it's safe to bend or rotate the cervical, thoracic, and lumbar spine. Spine precautions include bed rest, no flexion of the neck with a pillow or roll, no thoracic or lumbar flexion, manual control of the cervical spine anytime the ridge collar is removed, use of a log rope procedure to reposition the patient. A hard, rigid cervical collar is used to maintain cervical spine precautions in an immobilization with a confirmed cervical injury. If the collar is ill-fitting or soiled, it may be changed according to the hospital guidelines, while a second qualified person maintains that C-spine immobilization. Frequent assessment of the skin under the collar is important to monitor for skin breakdown. Spine clearance is a clinical decision made by the primary healthcare provider, often in collaboration with the radiologist. Spine clearance includes determining the absence of acute bony, ligamentous, and neurologic abnormalities of the cervical spine based on history, physical examination, and/or negative radiologic studies. The mechanisms of autoregulation are often impaired as a result of a traumatic brain injury. The most serious of injuries, the more serious the impact on the autoregulation of the ability of the cerebral, vascular, or modified systemic pressure, such that blood flow to the brain is sufficient. We want to monitor the patient's blood pressure, and we want to make sure that the pulse is also being watched. The patient may have hypo or hypertension. Cushing's triad, which is a classic but very late sign of increased intracranial pressure, consists of severe hypertension, widened pulse pressure, increasing difference between the systolic and the diastolic values, and bradycardia. This triad of cardiovascular changes usually indicates imminent death. Many hospitals use the Glasgow Coma scale to document neurologic status. A change of 2 points is considered clinically important, and we're supposed to notify the healthcare provider of any deterioration of 2 points or more on a Glasgow Coma value. The most important variable to assess with the brain injury is level of consciousness. A decrease or change in the level of consciousness is typically the first sign of deterioration in neurologic status. A decrease in arousal, increased sleepiness, and increased restlessness or combativeness are all signs of decline in neurologic status. Early indicators of a change in level of consciousness include behavioral changes, disorientation, and often subtle in nature. Report any of these signs and symptoms immediately to the healthcare provider or a rapid response team. We want to use a bright light to assess pupillary size and reaction to the light. Facial trauma may swell the eyelids, making this assessment difficult. However, Consider whether drugs that affect pupil dilation and constriction, such as an anticholinergic or adrenergics, have been used. Pupillary changes or eye signs differ depending on which area of the brains are damaged. Pinpoint and non-reactive pupils are indicative of a brainstem injury or dysfunction at the level of the treated pons. The oval pupil is regarded as a mid-stage between a normal size and a dilated pupil. Asymmetric or uneven pupils, loss of light reaction, or unilateral or bilateral dilated pupils are sometimes referred to as having a pupil that's showcasing a herniation of the brain from increased intracranial pressure until proven differently. Pupils that are fixed or non-reactive and dilated are a poor prognostic sign. Patients with this problem are sometimes referred to as having blown pupils. Pupillometers are used by some institutions to measure if the pupil is reactive and hard to assess patients. Want to follow the institution on what they utilize. Check for gross vision, making sure that the patient can see. We're going to monitor additional late signs of increased cranial pressure, which will manifest as severe headache, nausea, vomiting, and seizures. We want to assess for bilateral motor responses. We want to carefully observe the patient's ears and nose for any signs of cerebral spinal fluid, which could be a clear ring or a halo fluid, yellowish ring that we see on any kind of paper. We want to palpate the patient's head gently to detect any presence of fracture or hematoma. Look for any ecchymosis, tender areas in the scalp, and lacerations. Raccoon eyes are purplish discoloration around the eyes that can follow fracture of the skull's base. For psychosocial assessment, patients with any level of TBI usually have varying degrees of psychosocial changes that may persist for years or for the rest of their life. Changes in mobility and sensory perception may require rehabilitation or the use of assist devices. All the changes in health status may lead to difficulties within the family structure and with social and work-related interactions. The primary healthcare provider immediately requests a CT scan of the brain to identify the extent and scope of an injury. The diagnostic test can identify the presence of an injury that requires surgical intervention, such as an epidural or subdural hematoma. An MRI may be done to detect subtle changes in brain tissue and show more specific detail of the brain injury. MRI is particularly useful in the diagnosis of a diffuse axonal injury, but is not recommended for patients with intracranial pressure monitoring devices. Functional MRI, diffusion weighted MRI, and MRI spectroscopy may be done to more specifically detect axonic injury to the brain. The patient with a severe TBI is admitted to the critical care unit or a trauma center. Patients with a moderate TBI are admitted to either the general nursing unit or a critical care unit, where they are closely observed for the first 24 hours at least. Those with mild TBIs are usually sent home from the emergency department with instructions for home-based observation and primary healthcare provider follow-up. In some cases, the patient is hospitalized for a 23-hour observation by staff. Cerebral perfusion is not typically affected by a mild TBI. As with any critical injury patient, the priority for patients who have moderate to severe TBI is to maintain airway patency, breathing, and circulation. Specific nursing interventions for the patient with a TBI are directed towards preventing or detecting secondary brain injury or the condition that contributes to secondary brain injury, such as increased intracranial pressure, promoting for the patient with a TBI to have more problems with fluid and electrolyte balance, and monitoring the effects of treatment and drug therapy. Providing health teaching and emotional support for the patient and family are vital of the parts of the plan. If the patient develops a subdural hematoma at any point during a TBI, a craniotomy is performed to evacuate the clot. Care of patients who undergo a craniotomy is discussed under the surgical management in the brain tumor section. Preventing and detecting secondary brain injuries. We take and record the patient's vital signs every 1 to 2 hours or more often based on the patient's acuity. The primary healthcare provider may prescribe IV fluids or drug therapy to prevent severe hypertension or hypotension. Dysrhythmias and nonspecified ST segment or T wave changes may occur, possibly in response to stimulation of the autonomic nervous system or an increase in the level of circulating catecholamines, such as epinephrine from the stress of trauma. We want to document and report the presence of cardiac dysrhythmias, hypotension, and/or hypertension to the primary healthcare provider. Want to obtain the target range for blood pressure and heart rate from the provider and monitor parameters. The patient with a brain injury may develop a fever as a result of systemic trauma, blood in the cranium, generalized inflammatory response to the injury, or from an infectious source. Fever from any cause is associated with higher morbidity and mortality rates. The occurrence of a neurogenic fever is rare, and all other sources of fever need to be ruled out first. Maintenance of normothermia should be the goal and can be achieved by utilizing target temperature monitoring. TTM protocols allow the nurse to manage fever, evaluate effectiveness of therapy, and manage any unwanted side effects such as shivering or electrolyte abnormalities. Shivering can be detrimental by increasing the metabolic demand and may require the use of a paralytic agent and sedation. TTM can be implemented by using an invasive catheter placed by the healthcare provider or by the placement of an external cooling device to the body. Following institutional guidelines for the management of TTM, the Brain Trauma Foundation and American College of Surgeons have developed TBI guidelines, and currently there is no evidence to support the use of prophylactic therapeutic hypothermia in the management of a traumatic brain injury. Arterial blood gases, oxygen saturation, and end-tidal carbon dioxide values are all used to evaluate respiratory status and guide mechanical ventilation therapy. Hyperventilation for the intubated patient during the first 24 hours after a brain injury is usually avoided because it produces ischemia by causing cerebral vasoconstriction. Carbon dioxide is a very potent vasodilator that can contribute to increased intracranial pressure. We want to prevent intermittent and sustained hypoxemia, monitor peripheral oxygen saturation continuously in moderate to severe TBI. Hypoxemia damage brain tissue and contribute to cerebral vasodilation and increased intracranial pressure. Arterial oxygen levels are maintained between 80 and 100 to prevent secondary injury. If available, a hyperbaric oxygen therapy has been proposed as an adjunct therapy. It uses high-dose oxygen to treat ischemia and hypoxemia. The hyperbaric oxygen therapy is not FDA approved, however, but studies are being conducted worldwide to examine the feasibility and efficacy of using hyperbaric. If a patient is intubated, provide 100% oxygen before and after each pass of an endotracheal suction catheter. We want to avoid overly aggressive hyperventilation with endotracheal suctioning because of the potential of hypocarbia. Cerebral ischemia caused by even transiently decreased oxygen and either high or low carbon dioxide levels contributes to secondary brain injury. Lidocaine given IV or endotracheally is another option for these patients, and that can be utilized to assist in suppressing the cough reflex, which can help maintain our intracranial pressure where it's at and not increase it, which coughing can do. Patients with severe traumatic brain injuries often die. As the physiological deterioration begins, keep in mind that the patient may be a potential organ donor. Before death is declared, we want to contact the local organ procurement organization and determine whether the patient's consented to be an organ donor. This information is typically on the driver's license or other state-issued card or advance directive. The patient's wishes should be followed unless the patient has a medical condition that prevents organ donation. The organ donor agency representative and our primary healthcare provider can discuss the possibility of organ procurement with the family. Some families may not agree with the patient's decision, which can cause an ethical dilemma. Many healthcare agencies have an ethics specialist or a member of an ethics committee who can help in these situations. In 2010, the American Academy of Neurology guidelines have determined brain death, which were updated and remain the standard in the United States today. 4 classic prerequisites must be met to establish a brain death diagnosis, and that is coma of a known cause as established by history, clinical examination, laboratory testing, and neuroimaging, normal or near normal core body temperature, which is higher than 96.8, normal systolic blood pressure, which is higher than or equal to 100 millimeters of mercury systolically, and at least 1 neurologic examination. Many U.S. states and healthcare systems require 2 exams. No consensus has been reached on who is qualified to perform the head-to-toe brain death neurologic exam, but neurologists and critical care interventionists typically do them. Neuroimaging tests are not required to confirm brain death in most states or provinces, but are needed when a portion of the clinical exam or apnea test cannot be completed or uncertainty exists. It is important to note that there are different requirements between adult and children when determining brain death. Standard tests include a 4-vessel cerebral angiography and a radionuclide cerebral perfusion scan. Transcranial Doppler ultrasonography is gaining popularity and acceptance. Other tests that may be used at bedside are an EEG, an evoked potential, and a cerebral computer topography and angiography, and or a magnetic cerebral angiography. Nurses need to be prepared to continue to provide intensive care nursing and to manage family grief reactions, including rejection of the diagnosis. Nursing is at the forefront to identify family conflict and guide ongoing communication among the healthcare team and family members. Early nursing interventions can include the engagement of pastoral care, a social worker, an ethics consultation, and palliative care. For drug therapy, mannitol, which is an osmotic diuretic, is often used to treat cerebral edema by pulling water out of the extracellular space of the edematous brain tissue. It is most effective when given in boluses rather than a continuous infusion. Furosemide, a loop diuretic, is often used as an adjunct therapy to reduce the incidence of rebound from the mannitol. It also enhances the therapeutic action of mannitol, which reduces edema and blood flow, decreases sodium uptake in the brain, and decreases the production of cerebrospinal fluid at the cord plexus. So when administering mannitol, it has to go through a filter line in IV tubing, or if given IV push, draw it up through a filter needle to eliminate those microscopic crystals. For patients receiving either osmotic or loop diuretics, we want to monitor the intake and output, severe dehydration, and indications of acute renal failure, weakness, edema, and changes in urine output. Serum electrolyte and osmolarity levels are measured every 6 hours. Mannitol is used to obtain a serum osmolarity of 310 to 320, depending on primary healthcare providers' preferences and the desired outcome of therapy. We want to maintain strict measurements of the output every hour and check the patient's serum and urine osmolarities daily and sodium blood levels at regular intervals. Hypertonic saline is a hyperosmolar agent that can be used acutely, reduce the ICP, and improve cerebral perfusion pressure, and it works similarly to mannitol. The typical concentration used is 3% normal saline, but it can be as high as 23%. Nursing implications consist of continual neural assessments, monitoring of serial sodium concentrations and fluid status, and monitoring for pulmonary edema, especially if the patient has a history of cardiac or renal disease. Some organizations require an intensive care setting for close monitoring and a central line. The Occupying Evidence-Based Practice box summarizes a systemic review of comparing the effects of mannitol when compared to hypertonic saline to reduce ICP. Opioids such as fentanyl may be used with phenylated patients to decrease the pain and control restlessness if the agitation is caused by pain. Fentanyl has fewer side effects on the blood pressure and heart rate than morphine, and therefore may be a safer agent to manage pain with patients with a TBI. Propofol and Versed provide sedation to decrease ICP, but are not as effective for pain control. Most mechanically ventilated patients are on a combination of these drugs. An overwhelming majority of brain injury survivors have altered cognition, including decreased memory and impaired judgment. Cognitive impairments may interfere with the brain's essential for the return to independence and a reasonable quality of life. And If a large lesion of the parietal lobe is present, the patient may experience a loss of sensory perception for pain, temperature, touch, and proprioception, which prevents an ability to have an appropriate response to external environmental stimuli. A hazard-free environment is necessary to prevent injury. In collaboration with the rehabilitation therapist, integrated sensory stimulation program is the comatose tuberous patient's routine care activities. Sensory stimulation is done to facilitate a meaningful response to the environment. And say things like this picture is of your mother could be helpful. The picture is shown several times, but the same words are used to describe it. If auditory tapes or DVDs are used, they should be played no longer than 10 to 15 minutes. If the stimulus is present for too long, it may simply become white noise, which makes it meaningless for the patient. Most patients with TBI experience seizure activity as a result of primary or secondary injury. Be sure to initiate seizure precautions according to your agency's policy and procedure, administering anti-epileptic drugs to the patient as prescribed. The major role of the nurse and other members of the neuroprofessional healthcare team is to recognize the effect of the trauma on the patient and utilize a trauma-informed approach of care. Trauma-informed care is an approach to health care providing understanding, acceptance, and support for the victim and the trauma through positive adaptation and healing. Effective nursing care requires the understanding of the patient's life and how they are living through this trauma experience. Demonstrating understanding may foster patient participation in care while helping patients meet their personal goals. Trauma-informed care is built on 6 core principles, including safety, trustworthiness, transparency, peer support, collaboration and mutual support, empowerment, and culture and historical sensitivity. The patient with a mild brain injury recovers at home after discharge from the emergency department or hospital. We want to teach the patient who has sustained a mild brain injury that if signs or symptoms affecting physical, cognitive, or emotional function should occur, the patient should be referred to a healthcare provider training concussion management. We want to provide the patient and family with educational materials that will alert them to symptoms and management options. The patient with a moderate to severe brain injury requires long-term case management and ongoing rehabilitation after hospitalization. Behavioral interventions are used by cognitive and brain injury rehabilitation specialists to help both the patient and family members develop adaptive strategies. A number of specialized brain injury rehabilitation facilities are available in the United States. Some facilities offer non-invasive neuromodulation, which alters nerve activity through a targeted delivery of a stimulus to modulate abnormal available neural pathways behavior which caused the injury. The major overall desired outcome for rehabilitation after brain injury is to maximize the patient's ability to return to the highest level of functioning. Activities such as occupational therapy, physical therapy, and speech pathology, language therapy may continue in the home after discharge from the hospital or rehabilitation facility. Adaptation of the home environment to accommodate the patient's safety may be needed. For example, smoke and fire alarms must function properly because the patient with a brain injury often loses a sense of smell. Home evaluations and referrals to outside agencies are completed before discharge. Want to be sure to refer the patient and family to a registered dietitian nutritionist for health teaching regarding health nutrition to prevent weight gain from decreased activity or stress eating. Many patients with TBI gain significant weight within a year of their injury, most likely because of inactivity. Patients with personality and behavior problems respond best to a structured and consistent environment. We want to instruct the family to develop a home routine that provides structure, repetition, and consistency. Remind the family about the importance of reinforcing positive behaviors rather than negative ones. Most patients with moderate to severe TBI are discharged with a very low long-term physical and cognitive disabilities. Changes in personality and behavior are very common. The patient and family must learn to cope with the patient's increased fatigue, irritability, temper outbursts, depression, loneliness, and memory problems. These patients often require constant supervision at home, and families may feel socially isolated. We want to collaborate with the case manager to refer families and patients to local chapters of the Brain Injury Association of America for information and support, as well as other resources that include religious, spiritual, and cultural leaders. We want to evaluate the care of the patient with a TBI based on the identified priority problems. Expected outcomes for that patient are to maintain cerebral tissue perfusion, learn to adapt to altered mobility and sensory perception changes, if any, and have minimal alterations in cognition or understand how to compensate for cognition changes when necessary. Brain tumors can arise anywhere within the brain structures and are named according to the cell or tissues where they originate. However, cerebral tumors are the most common. Primary tumors originate within the central nervous system and rarely metastasize outside the area. Secondary brain tumors usually are a result from metastases from other areas of the body, such as the lung, breast, kidney, skin, and GI tract. Regardless of the location, any tumor can expand and invade, infiltrate, compress, and displace normal brain tissue. Similar to the pathophysiologic changes that occur in patients with TBI, these changes can lead to cerebral edema or brain tissue inflammation, increased intracranial pressure, and neurologic deficits. In some cases, pituitary dysfunction can result. Cerebral edema results from changes in capillary endothelial tissue permeability, which allows plasma to seep into the extracellular spaces. This leads to increased intracranial pressure and, depending on the location of the tumor, brain herniation syndromes. A variety of neurologic deficits results from edema, infiltration, distortion, and compression of surrounding brain tissue. The cerebral blood vessels may become compressed because of edema and increased intracranial pressure. This compression leads to ischemia of the area supplied by the vessel. In addition, the tumor may enter the walls of the vessel, causing it to rupture and hemorrhage into the tumor bed or other brain tissue. Many patients who have brain tumors have headaches and seizures from interference from the brain's normal electrical activity. Pituitary dysfunction may occur as a tumor compresses a pituitary gland and causes a syndrome of inappropriate antidiuretic hormone or arginine vasopressin deficiency. These disorders result in severe fluid and electrolyte imbalances and can be life-threatening. Brain tumors are usually classified as benign, malignant, or metastatic. This may or may not be treated depending on their location. Benign tumors such as meningiomas can usually be removed and are generally associated with a positive outcome. Malignant or metastatic tumors such as an astrocytoma require more aggressive interventions, including surgery, radiation, and/or chemotherapy. A second classification system is based on location. Supratentorial tumors are located within the cerebral hemispheres above the tentorium. Located beneath the tentorium is the infratentorial area, and where tumors may also be occurring. The exact cause of brain tumors is unknown. Several areas under investigation include genetic mutations and a variety of environmental factors. The use of cell phones have been investigated as a cause of brain tumors, but findings are unconfirmed. Brain tumors account for a small percentage of all cancer deaths. Primary brain tumors are relatively uncommon, but many more people have metastatic lesions. Malignant brain tumors are seen primarily in patients ages 40 to 70 years of age, and the survival rate is low compared to that of other cancers. The desired outcomes of brain tumor management are to remove the tumor or decrease the tumor size, improve quality of life, and improve survival time. The type of treatment selected depends on the tumor size and location, patient symptoms and general condition, and whether the tumor has reoccurred. In addition to traditional interventions, a number of experimental treatment modalities are being investigated. These include blood-brain barrier disruption, recombinant DNA, monoclonal antibodies, new chemotherapeutic drugs, and immunotherapy. Traditional radiation therapy may be used alone after surgery or in combination with chemotherapy and surgery. The primary healthcare provider may prescribe a variety of drugs to treat the malignant or metastatic tumor, manage the patient's symptoms, and prevent complications. Chemotherapy may be given alone in combination with radiation and surgery, and when tumors are very large. Although these drugs may control tumor growth or decrease tumor burden, the benefit does not last. Chemotherapy usually involves more than one agent that may be given IV, orally, intra-arterially, and/or intrathecally through an Mayo reserve placed in the cranial ventricle. When given systemically, the drug may be lipid-soluble to cross the blood-brain barrier. Commonly used oral drugs are lomustine, TMZ, procarbazine, and methotrexate. Vincristine may be given IV in combination with other drugs. We want to monitor for side effects of these drugs, which are very similar to those of any chemotherapy drug. Direct drug delivery to a tumor is another treatment option. Dish-shaped drug wafers, such as carmustine, may be placed directly into the cavity created during surgical tumor removal, which is interstitial chemotherapy. This therapy is usually given for newly diagnosed high-grade malignant tumors, but recurrent tumors may also be treated with this method. Other drugs used are molecularly targeted. Examples are L-lotribine and bevacizumab. Analgesics such as codeine and acetaminophen are given for headache. Dextromethasone is given to control cerebral edema. Keppra or other anti-epileptic drugs may be given to prevent seizure activity, and proton pump inhibitors may be administered to decrease gastric acid secretion and prevent the development of stress ulcers. Stereotactic radiosurgery is an alternative to traditional surgery. Several techniques are used, including the modified linear accelerator, using accelerated X-rays, a particle accelerator using beams of protons and isotope seeds implanted in the tumor. The gamma knife is a device that can be used in an SRS procedure in which the single high dose of ionized radiation is focused on multiple beams of gamma radiation produced and selective without damaging the surrounding healthy tissue. Tumor treating fields is a technology modality that delivers regional low-intensity, intermediate frequency specific alternating electrical fields to a solid tumor. The therapy consists of placing transducers directly on the skin on opposite sides, directing alternating electrical fields through the tumor and causing the cancer cells to slow or stop cell division. A craniotomy is a surgical incision in the cranium to access the brain, may be performed to remove the tumor, improve symptoms related to the lesion, or decrease the tumor size, debulking. The challenge with the neurosurgeon is to remove the tumor as completely as possible without damaging normal tissue. Complete removal is possible with some benign tumors, which result in a surgical cure. After surgery, the patient is often admitted to the critical care unit or a neurosurgical unit for frequent observation. Patient with a brain tumor is managed at home if possible. Maintaining a reasonable quality of life is an important outcome for recovery and rehabilitation. Unless the patient has a significant degree of disability, no special preparations for home care are needed. Patients with hemiparesis need assistance to ensure that their home is accessible according to their methods of mobility, an example, a cane, a walker, or a wheelchair. The environment should be made safe to prevent falls. For example, teach caregivers to remove scatter rugs and to place grab bars in the bathroom. Information about the selection of rehabilitation or chronic care facilities, if needed, can be obtained from the case manager or discharge planner. The selected facility should have experience in providing care for neurogenically impaired patients. A psychologist should be available to provide input in the evaluation of the cognition disabilities that the patient may have. Seizures are a potential complication that can occur at any time for as long as 1 year or more after surgery, so we want to provide the patient and family with information about seizure precautions and what to do if a seizure occurs, and we want to teach the need for follow-up appointments to monitor for therapeutic levels of anti-epileptic drugs.